Before we start, if anyone wants to ask any question. Okay, so we will just start with the topic of pancreatitis. So, what is pancreatitis? Yes, Tayyaba? Can all of you hear me? Zishan, would you like to say what is pancreatitis?
Pancreatitis, it is due to the inflammation of the pancreas with release of pancreatic enzymes that will result in abdominal pain and certain.
Okay, so it will be either acute or chronic. Okay. Okay, so
it's
yes.
mostly acute.
No, it can be chronic.
Chronic?
Yes, there are many causes of chronic pancreatitis. Okay. So anyways, if we just focus on acute pancreatitis, so as an anesthetic, what are the main considerations or main problems which we should be focusing when you are dealing a patient with acute pancreatitis? How will you diagnose it? Is there any specific diagnosis? Is there any specific diagnostic test?
Yes, sir. There are serum levels of amylase and lipase. Lipase is more specific.
Is it diagnostic test?
Yes, sir.
The answer should be that it's actually usually it's a clinical diagnosis. There is no specific diagnostic criteria. These are all along with clinical history. Okay, like if, for example, patient does not have any clinical symptoms and has raised enzymes, so it will not be significant.
Right.
So there will be journal markers, journal characters. So because when they are asking you this question, the thing which you should be focusing are what are the problems in it. Just can you just try to summarize main problems which you will be facing if you are dealing, because you know pancreatitis has two things. Number one, there will be a patient with acute pancreatitis for any emergency surgery. This is one challenge. There is a patient with acute pancreatitis in management in ICU. Okay, and there is some patient with acute pancreatitis with the surgery to treat pancreatitis. Usually there will be three things or three scenarios which you may be asked. Okay, so in either of them, like if it is emergency, you have to proceed. Am I right? If it is in ICU, you are giving the treatment. So these are two things. The third will be the least common thing, that a patient with pancreatitis going for a surgery to treat pancreatitis. Okay, so what will be the common things which you can face in all of these scenarios? What will be the problems?
Sir, the patient has epigastric pain. Mostly it is the pancreatitis develops in alcoholics and in patients with gallstone disease. Then when pancreatitis has developed, there is biochemical abnormalities like electrolyte abnormalities and There can be signs of peritonitis, peritoneal fluid, ascites, and
You
vomiting.
are just slipping out. You are slipping out from main thing to very distracted things. I'm asking you as an anesthetist, what will be your challenges? So pain is the main challenge. Okay. Hemodynamic instability is another challenge. Electrolyte
Yes,
imbalance is another challenge.
yes, sir.
Be very practical. Am I right? You just
Right,
have
sir.
to tell the things which are important rather than just telling everything. Okay.
Vomiting is important for us also.
Well, like electrolyte imbalance because of the pain and the acute abdominal symptoms. Okay.
Right.
Nausea, vomiting, leading to and then usually if now then you can enter into these things which I have just told you are related to the symptomatology. Okay. The other component of pancreatitis will be because of the reason. Okay. So what are the
Right.
common causes of acute pancreatitis?
So the most common causes are alcohol disease, gallstone disease. Then there is some kind of obstruction in the biliary tract, like duodenal strictures, or even ascariasis is sometimes said. Then there can be trauma, which can cause abdominal trauma, and certain drugs like antibiotics, HIV drugs, and some immunosuppressive drugs. Um,
Okay. Related
Baki
to
suppressed.
like most common will be related to the biliary tree, alcohol, or any infection or any
Yes,
drugs.
sir.
Really, if you just can divide it, you can divide it in like that. Okay.
Right.
So okay. So what will be the supporting tests or investigations? Because I told
So,
you that the main there is no specific diagnostic test like you
yes,
test
sir.
it and
Yes,
say
sir.
that yes it is pancreatitis, because usually pancreatitis spontaneously develop less common than because of some reason. Okay. So
Yes, sir.
the things will be related to that cause as well usually. Okay.
Yes,
So
sir.
what will be
Cause and
the
the mostly the effects of pancreatitis we have to see
yes, so what will
through
be that
certain tests.
helping investigation you can then do the pancreatitis,
So
the
we can
pancreatic,
do
the
we can do
non-specific
the electrolytes,
electrolyte
maybe
before the
amylase and lipase,
non-specific, no, non-specific inflammatory markers
inflammatory marker like
like
CRP.
CRP or ESR. You
SR.
will not forget it. There will be
Yes, sir.
sign of infection. Infection can be a cause. So WBC may be
BC
raised,
count.
or
Yes,
any
sir.
other finding in CBC. This is it. In that way, you will not forget. Okay.
Right.
Then you can say about liver functions. There will be raised liver function in pancreatitis with relation to hepatitis,
Yes, sir.
pancreatitis with relation to CBD stone. In that, there will be jaundice. Okay.
Yes, sir.
Is it better to tell or the way you were telling?
No, it's better.
Be very straight. If I'm saying something wrong, you have to mention it without hesitation. Okay.
So
Because
among the blood tests, we will do the CRP, WBC count, or full blood count, then electrolytes. Then we need LDH and LFTs. Mainly, we are
then
looking for
you
AST
can
in it.
say that pancreatic enzymes will be you can be in the that inflammatory markers. Then you can tell about pancreatic enzymes, and then you can tell the other things which I have telling. Okay. And
Right, sir.
the other diagnostic tests will be ultrasound to see any
Ultrasound.
CBD stone or biliary tree, ERCP, ERCP. Okay. ERCP or MRCP they do to see the cause. Okay. Or
Then CT scan
if
for
it is,
reading of severity.
yes, if it is like it is like traumatic origin or something like that, that it will be that component will be there can be resulting. For example, pancreatitis is associated with what other things? What are the nearby structures? Pancreas is just near to diaphragm. Okay.
Yes, sir.
So diaphragm, there is a friend which is very angry, which can become angry very easily. So there can be
Right.
pleural effusion. Am I right?
Right.
And so like
Can be ascites, there
lungs
can
will
be
be,
abdominal
yes, there can be
viscous
ascites.
perforation.
Yes. Okay. So now in that way, you will not be able to forget when there is, you are talking about lungs, you can tell that there can be pulmonary edema or pleural effusion or ARDS. Like ARDS and pleural effusion will be the better answer. Okay. So in that way, you will be going in a system and you will not forget, by the way, you will not have to cram what are the things in when someone asks you about pancreatitis, I am really surprised that despite being a Pakistani student, you have not tell the name of Ranson's criteria yet. Because if someone asks, they will not tell these things, and that will be jumping to the
But
Ranson.
that is not a
No,
diagnostic test.
no,
Those are
no, no,
just for
no.
severity grading.
Yes, that's what I'm telling you. That actually you can use the word so that examiner knows that you know about it, but you will be telling that first thing will be to see the cause. Severity will be after that. Like you are just telling these things about the diagnosis and the possible cause, and then you will
Yes.
rate the severity. Because I will just hand over to Tayyaba for this answer, because this may be not be usually asked in MCPS, most probably. ICU severity scoring system, they can ask you as well. So, but I will just add Tayyaba now from here. So these are the things which you, rest will be, just a second, Tayyaba. The rest of the things will be generalized. Like you will be, just like any ICU patient, you will be going towards the severity of a patient with multi organ involvement. That will be with Apache, SOFA, and this
Then
one. These
there
specific
are
of
Ransom criteria,
Ranson related to CT
Glasgow
scan
scale.
or Glasgow. Okay, so these will be in that way. Even if you are not able to tell details of Ranson criteria, they will not fail you. Okay, you for Ranson criteria, remember one thing: if you know the numbers, don't you need to not to tell the numbers to start with. You can tell the parameters first and how to interpret, and you will be saying that these are just telling the prognosis of the patient. Okay, so this is the way you should be telling, and then they can ask you if they have to ask you in details the ICU scoring system, they can ask you. Otherwise you can just say that acute physiological and chronic health assessment evaluation and sequential organ for failure assessment. You can just use the name, and you will be if you are very perfect in speaking, then you can tell the parameters as well in which they are looking at this parameter, and like that. So you can make your answer like that. But first of all, go step by step, because if you will be step by step, you will not miss anything. Okay,
Yes.
so
So there are two things that we do on admission. One is Apache 2. If the score is more than
just
8,
leave
then
it,
it
Zishan, leave it for Tayyaba. I just want to involve as many people as much possible. Okay, so up till now you have made a concept that how pancreatitis will be approached. Now the main focus will be towards the identifying the cause and go for the management. Okay, so Tayyaba, I will be asking you this question: what are the different ways to assess severity of morbidity and more prediction of mortality in ICU? Not specific, you can tell in the last part of your answer, you can tell about the specific things, but generally how to assess the severity of any problems in ICU.
Okay, sir. Well, when talking about the pancreatitis, as you have already
No,
said, that this.
first of all, tell about the journal scoring systems.
Okay, so there are some journal scorings. Whenever a patient reaches the ICU, we do some scoring system to just see the severity of disease. So that is the Apache, which we do in a patient when we receive a patient in a ICU. And then for the nutrition status, we do the
Sorry,
Nutric
Tayyaba.
score.
Sorry, Tayyaba. I will ask you to add one thing, that in addition
Okay.
to the journal evaluation of the patient, the general
Yes,
evaluation
yes.
of the patient, airway, breathing, circulation, disability, A, B, C, D, E, you can just so that it is not your not telling you you're wrong. But if you will start with that one, that the impression will be even better. Okay. So
Yes,
if
sir.
any severity will be according to the journal assessment of the patient: airway, breathing, circulation, presence of any inotropes, vasopressors, okay, any support. So then after that, these are the criteria which you are telling. Okay, Apache.
Yes, sir. So first one will be in addition to the journal and physical health of the patient and all the criterias of the ICU. After doing that, we can do some scoring system to just see the severity of the disease. So first of all, about the journal health of the patient, which includes the Apache score, which we do very on the very regular basis, and it includes 12 variables, and that is a long list. If you
Yes.
want me, I can tell
No, no,
you
no.
that
Leave,
list
leave,
also.
leave it. Leave it for a while
Okay.
because it's
So, okay, the
anyone
second,
can say
yeah,
no. So Apache, how to interpret Apache? That's more important.
yeah, in pancreatitis, if you say specifically, I only
No,
know
no.
that if
We have
Apache is
not.
greater than.
We have not reached Apache pancreatitis yet. Okay. Just tell me
So
how to
basically,
interpret
it's
Apache.
okay. Okay, it basically if the score is of 35, it predicts a mortality of greater than 80%. I only know this.
Okay. No, no. Like you will be. You will be.
Sir, it's acute physiological and chronic health evaluation score.
Yes. Okay. What else?
So you asked about its
Interpretation, like Tayyaba just said that it will be telling the mortality
The
or morbidity.
mortality, yes.
Can you add to this word a little bit? Okay, okay, Tayyaba.
It contains 72 scores.
No, that is we are not
That's
talking
a
about.
total points.
We are
That's
talking
the total
about the
point.
interpretation. You see, listen. The main reason for our discussion. You all have the books. You all are very intelligent. You can read anything. My purpose is just to make your brainstorming exercise, so that you know what is important and what is not important. That's why you will see, all of you will see, that I'm not too much indulged in telling you the numbers, scoring, because this is not a problem. The problem is the interpretation. Problem is when to tell the things and what next. You tell the numbers, they are not interested in listening to the numbers. They just want to see that it's not an accurate thing. It is not valid in every patient. Okay, is it valid? Is it 100% accurate? That's what I
No, sir.
want. So you just have to tell that it just give an idea and possible prognosis. It's not absolute because they are changing it every now and then. They are changing it. Okay, so they are updating it. So you just approximate is the word which I was just, as Jamil has written in the message. So this is one thing. And what else? Sequential organ failure assessment. Okay, so SOFA, what is difference between SOFA and Apache? They will ask you this
Sir,
question.
Apache we can do, yes. Sir, we can do only Apache on the first day, and the SOFA we can do on the repetitive basis to see the prognostic, to see the, you can say the treatment which you are, the response of the treatment basically, which you are
Yes,
giving to the patient.
yes. Okay, and the what is difference between Q SOFA and SOFA?
Sir, basically Q SOFA was developed for the quick assessment in as in the emergency. It only contains on of the three parameters, which are the about the hemodynamics, which that include the systemic BP, tachypnea, and the altered state. So you can
Again,
just
Tayyaba,
just to
again, Tayyaba, if you start your answer, you have told perfectly, but I again want to just tell that the difference between Q SOFA and SOFA is that there is no lab investigation. Q SOFA, it's very quick, as the name is telling, quick. So it is just extracting the things, or then you are just trying to find the basic direction of your management, and you are doing just on the basis of clinical evaluation. Am I right? So this should be your answer, because that will, again, Tayyaba, I'm just refining it. You know everything. Okay. So the thing is that when someone asks you about difference between Q SOFA and SOFA, or you can just tell that because for SOFA we need more time for the investigation, and so the direction of treatment can be delayed, may be delayed. So the purpose of introducing QSOFA was any patient who has some of the parameters or some of the scoring system towards this line of sepsis or towards the direction of patient deterioration, you will be immediately start the bundle. You will be immediately taking the samples and for cultures and starting the fluid resuscitation and starting the, so this is the concept. So that's what I want you people to learn, because that will make you special rather than just trying to reproducing the book. Try not to reproduce the book as much as possible. The more you will be telling the concept, the better you will be, and you will not forget. The more you will try to reproduce the number of pages and sides of the book, you will forget. That's what my message is. Okay. So there in addition to this QSOFA and Apache, there are some other scorings which they use.
Yes, sir. Yes, sir. We do one more score on the admission of the patient in the ICU, that was according regarding to the nutritional status of the patient, that who needs nutrition more aggressively. That was a Nutrix score that we do on the daily basis.
Okay. Rabia, would you like to tell about the other anatomical and physiological scorings which they use? Just name, if you can just tell.
Yes, sir. Sir, Apache scoring system, which is done
We
on
have
the
discussed it. What about what else? Don't repeat.
So it's a SAP score, simplified acute physiological score, and then sir, mortality predicting Meyer model.
Every there are some injury severity score, some in anatomical scores as well. Okay.
Yes, sir. And also, sir, multi-organ dysfunction score, MOD score, and some surgical score, which is P-POSSUM for the and therapeutic intervention scoring system.
Yes, and then there are some specific like this. Now we will go into the specific.
Like Ransom.
Ransom for pancreatitis. For delirium, there is a scoring system. There is sedation. There
CAM
is a
ICU.
system. Okay, so these are the thing that you will be starting from the general assessment of the patient. Then you can tell that there are some specific scoring systems which they have devised just to predict the prognosis of the patient. And then there are some scores which are related to specific disease or specific problem which we are facing, just like nutrition is one of them, delirium is one of them. Rifle criteria is used. Rifle, why not you use the word rifle? What about patient going in encephalopathy? The patient is not necessarily ICU patient is intubated. Do they? What about the criteria for the assessment of the need for intubation? These are all part of the severities. If the patient is now fine and now becoming in respiratory distress, it will be leading to any respiratory support. This is also you have to mention. Okay, so you just think about the vital organs and you can tell about it. Kidney, heart, this one, brain, general delirium, or like other things. Okay.
Sir, GPS, sir, pneumonia, for pneumonia curve 65 and CP score.
Like
And
just
for
Curve is outside the ICU, isn't it?
What's that?
Sir, curve is outside is done outside the ICU.
I don't know, but the thing is that don't like use the word which you can tell a little bit of words. I don't know anything about the score Rabia told. Okay, so I cannot comment
Sir,
about
this is used for pneumonia. Yes, sir. Curve 65. This is used for pneumonia. Any patient coming with the respiratory distress and the infection
just tell
in the
me one
outside
thing,
the
if the patient in an ICU or so because that we will be distorting from our topic, but that is a ventilator associated pneumonia, community acquired pneumonia, and hospital acquired pneumonia. Okay.
Yes, sir.
So these are actually three different entities, but hospital VAP is part of ventilator associated
CPIS criteria.
Okay, so
yes,
I
sir,
think
that CPIS criteria used.
anyways, I think we will go on to the next part of pancreatitis. The remaining part, how to treat. Atik bhai, would you like to say something? How to treat acute pancreatitis? Okay, Nadir. Yes, Atik bhai, yes.
Sir, we can treat the acute pancreatitis like generalized treatment and supportive and as well as specific treatment, sir.
Mhm.
In generalized treatment, sir, we will take the small history, and sir, you're talking about the, sir, management or specific treatment, sir.
What I have asked you, what is different between management and specific treatment?
Management is from
is there any specific treatment for pancreatitis?
Sir, in the sir, removal of the offending agent, supportive treatment, and
so that is not a specific management. Again, you see, just whenever someone is asking you the management, your approach will be the same, Atik bhai. Airway breathing circulation approach, from where we start usually. So your answer can be in the same way.
Sir, airway breathing and circulation, and sir, in airway we have to we will have oxygen and look for the airway, and sir, then breathing, then circulation. In sir, there must be pain management, sir, and if the patient require ventilation, there should be some ventilation as well, sir. And
okay. What else?
And sir,
listen. You know what I want you to correct yourself. You are just confused what to say. You know everything, but you are unable to tell me when I'm asking you. Your answer should be, let just listen and listen carefully. That if someone asks you how will that you have diagnosed, we have discussed the diagnosis, we have discussed the severity, that etc etc etc. Okay, so now you will be saying, if someone asks you how to manage it, so you will be saying the management will be according to the condition and the cause of pancreatitis. So this should be your first answer in this scenario. But generally your approach will be airway breathing circulation. I will be making sure patient is having good ventilation support, and then patient is breathing well. And then I will be looking at the vitals. If patient is needing hemodynamic support, I will be giving hemodynamic or respiratory support. And then my focus will be to treat the cause. If it is infective cause, I will be doing on the lines, or patient is having high Q SOFA. So I will be starting managing according to the lines of sepsis. If there is some involvement of the hepatobiliary tree, I will be discussing with the surgeon or the gastroenterology team to have their plan, what they want to do to relieve the obstruction. Okay. And further, if patient is intubated or patient is on, so the general ICU care, patient should be admitted to ICU and the general care should be provided. अब आप मुझे बताइए कि what's the difference in what I have told you and what you were trying to tell without any order. And you will be the examiner will be irritated, and he will be pushing you like, I give you a stronger dose and you forget what you were telling. Am I right?
Sir, you are right, but sir, there must be some plan of if we approach the patient, then we will take history and sir, the examination. Then this is all called management, sir. And
okay.
the specific treatment and investigation as well, sir. And then we will go for in a specific treatment. We have got supportive treatment and sir, and the specific treatment as well, sir. In the supportive treatment, we will approach the patient. We will give if the patient is dehydrated, we will give fluid and as a plug check. That is a we will improve that as well, sir, according to the situation. And sir, the second one is if we need, if we will go management and treatment will go side by side. We will start from ABC, and if they are okay, then we will send investigation for further if it is pancreatitis or something else. Then we, after investigation, we take confirmation that it is pancreatitis. Then we will start nutrition, pain management, and sir, generalized systemic complication management. And sir, we will also see the electrolytes imbalance. If there is, we can correct it as well, sir. And sir, we will take nursing care in the ICU, especially sir, to pancreatic patient by starting nutrition early.
Okay, what will be the indication
Or
for
we-
surgery?
if-
What will be the indication for surgery in acute pancreatitis?
Sir, if it is it has having necrotic tissue and pseudo necrosis, then we can be done. And if it is a funding agent, we can do ARCP as well, sir.
Surgery. We are
Urgent,
not talking about ERCP, MRCP. This is not surgery. We are talking about surgery.
procedure, sir. I'm talking about procedure. Urgent
Surgery.
ARCP.
I'm talking about surgery.
Surgery is pseudopancreatitis is there and intestinal obstruction is there, then we will have to go for surgery as well, sir.
What will be the main thing? For that, you have to open it.
If necrotic tissue is there,
tissue, what will you do in necrotic tissue? It will bleed like
Remove-
anything. In necrotic tissue, you need to give if for example, there is, it's not responding to antibiotics, then you will go for surgery. Okay. Drain.
Okay, sir.
So the initial which you can tell is abdominal compartment syndrome.
Abdominal compartment. Yes, sir.
So for that thing, you have to open it by laparoscopy or whatever. You have to open it. Otherwise, patient will have severe problem. Infection is not as emergency because in infection. Otherwise, for example, if it is you are telling necrotic tissue. You are right, but this will not be the first line. The first line still will be to start the antibiotics. Okay.
Okay.
Surgery, sir, but the thing, you see, you are trying to go into the thing which is not primarily related. Abdominal compartment syndrome is more important to anesthetist than.
Sir, excuse me, sir, Zishan. In the operation theater, we maybe this patient can come with acute abdomen. This patient can
We will
come.
go. Just a second. Just be systematic. Well, I try to answer me, but I am asking you. Okay. First, now we started from our general assessment of a patient. Then we diagnose the patient. Then we see the assessment of the severity. Then we say how to manage it. Because why I was using management now, because we have already discussed all these things. So when in Viva they have reached up to this point, you will not tell the things again which you have being asked again. We have just discussed. So you have to start the management on the basis of the information which you had. Okay. Or you will be saying the same which I told you, that you will be approaching the patient, you will be seeing any serious things to be noticed like airway, breathing, circulation, and then you will start on the line of sepsis. You will be seeing if any specific management is needed, like for example related to obstructive, like in that case you can say ERCP or MRCP or removal it. Okay. Or if there is development of abdominal compartment syndrome, or there is non-responsive cyst or something like that which needs drainage, then you will go. Because what is the problem if you take the patient to surgery for removal of the number one, approach is difficult. It is not a very easy approach. Number one. Number two thing is that it will bleed a lot. And the patient will, in this scenario, patient will be very patient will be unstable.
Because of the sepsis.
Because if the thing will be that if there will be such a severe infection, there will be some hemodynamic sequelae. Okay. So that patient will not be a very suitable candidate to straight. You have to optimize the patient and then go for the surgery. But abdominal compartment syndrome, if it is occurring, you have to deflate. Otherwise, you will lose the patient. Okay. Or otherwise, in abdominal compartment syndrome, will there be effect of fluid management?
Yes, sir. There, before opening, we have to.
You are right. You are right. You can try, but your management will be futile unless you open it. Okay. Like you are giving everything, you are giving whatever you want to give, vasopressor, etc., etc., etc. But this is physical obstruction. What is abdominal compartment syndrome? What is abdominal compartment syndrome?
When the pressure of the abdomen is more than 22 mmHg.
Just this is when you are coughing, and if you have eaten a Pakistani meal, your abdominal compartment pressure should be like that. Okay, so this will be abdominal compartment syndrome.
No, sir. No, when there is the pressure in the sir,
It
it
is
is the
acute organ dysfunction.
No, please, Tayyaba, let him speak, please. Yes. Yes.
Sir, when the abdominal in the abdominal compartment syndrome, when the pressure in abdominal pressure is more than 22.
Okay.
Or more than 30.
Whatever number, forget about numbers, go forward. What else?
And it because of the pressure, the pressure is compressing the abdominal like.
Atik bhai, you are not telling, you are not telling the specific word. Please, the new development of newly diagnosed organ dysfunction, along with the signs of high abdominal pressure. Okay, this is the answer of abdominal compartment syndrome. You are only focusing on pressure. Pressure is one thing. Pressure, when you are coughing or you are sneezing or when you are doing anything else, you have a constipation, your abdominal pressure can be high, but it is not causing abdominal compartment syndrome. Okay, so abdominal compartment syndrome is development of newly diagnosed organ function with increased abdominal pressure. Okay.
Okay.
So in that scenario, you will be going for surgery. Okay, Tayyaba, now what you were saying, the same thing or something else?
No, sir, the same thing.
Okay, so because you know that Atik bhai, what will happen if you will be telling like this? You are wasting your time in the viva, and you are irritating the examiner because that's not what he wants to listen. Okay, so please try to be, and the one you be using the word I was just about, maybe you were saying it is cyst. It is not necrosis, it is cyst. When it is closed cavity and it's not, because if it is such a condition that even antibiotic is not reaching it, then you have to drain it. Am I right?
Sir, pseudocyst, necrotic tissue and pseudocyst abscess. I divided three things, sir.
Again, please. Cyst. What else?
Sir, pseudocyst, abscess, and necrotic tissue.
Necrotic tissue. Atik bhai, just tell. I am just trying to explain you the reason. When it is covered, okay, like if it is pseudocyst or it is necrosis with the cyst, within the cyst, then now the antibiotic cannot reach it. Okay, so then you have to drain it surgically. You understand my point? Not only it will be only, not every infection needs to be drained for pancreatitis. It's not like boil on the skin. That is something else. This has very specific indication for surgery. Okay, so it is necrosis with the walled off necrosis. Yes, Nadir?
Sir, mainly surgical indication when medical treatment failure or with organ dysfunction, or Dr. Teek is saying about abscess. So it's a pancreatic bed or some collection, then we will do for surgery, sir.
Nadir, that's what I was discussing. You are not listening, I think. You will be doing, you will be doing the surgery when it is not responding as you told, and there is there are chances of antibiotic not reaching the place. Because it's a cystic pseudocyst or cyst which is covering it, and antibiotic is not reaching it.
Okay, okay, sir. Okay. Yes.
Okay, so I think any aspect remaining in pancreatitis? Atik bhai,
So you haven't talked about the analgesia, especially analgesia in pancreatitis is very important.
okay. One thing. What else? What about fluid management? What about pain management? These two things are left. What else?
Sir, food management, pain management, and nutrition serve as well.
Okay. So what will be the management plan for pain?
Sir, we can give morphine for multimodal analgesia, patient control analgesia with IV.
Is morphine a good choice in such patients?
Yes, sir. Morphine is a drug of choice for pancreatitis, sir.
Morphine is a drug of choice. If
Yes,
pancreatitis is associated with the liver dysfunction as well, which is there is always a chance. So would you give morphine?
Sir, but according to sir, some article I have read that morphine is a
Atik bhai, please try to think logical as well. You will use the same word which you have read in the book. I am requesting you this thing, and you are doing the same mistake again and again. Prove it. Okay, now I have given you a scenario. Pancreatitis was because of liver dysfunction, and you said this is the drug of choice for pain related to pancreatitis. So, what about use of opioids and the increase of sphincter of oditone?
So that can be, sir, Inspector Odai, that can be relieved with the glucagon or.
So you will first give opioid, and then you will give glucagon to relieve the tone. So why don't you avoid these?
No, sir. In the specific management, you have told me if you will give morphine, what will you do? If you have given morphine.
No. I did not ask you.
We can always also give another
So how can you use the word that morphine is the best choice?
Sir, multimodal analgesia.
Thank you very much. Thank you. For heaven's sake, help me out. Multimodal analgesia with just, you see, your answer will be very good, Atik bhai, when you are trying to be simple. You read a word from our article and you are just trying to throwing it away, and examiner will kill you. I guarantee you. And if you will be very specific like this, unless it is a very safe thing, it is not safe thing. You will say that if there is no contraindication to morphine, which may be there because of associated liver dysfunction, then morphine will be a very good choice because patient will have severe pain, and morphine will be giving a good analgesia. That now just tell me, is it safe answer now? Or like you said?
Sir, you are also always
to give the advice.
I'm sorry. Yes, Jamil, please.
Sorry, I just want to give advice to Dr. Atik that don't start with controversial things. The morphine is the controversial. Until unless you prove that there is no obstruction, no CBD stone, and there is other means the liver failure. Then if you clear everything, then you can use the morphine. But better avoid to start with controversial thing. You just start multimodal analgesia, it will be good. Okay, if the examiner asks you what about the morphine, then you prove. Otherwise don't start your answer with these things. You
Okay.
Always
yeah. Okay, so Atik bhai, what about giving epidural? Would you like to give epidural?
Sir, we can give epidural as well, sir, and we can always use sir, celiac plexus block if it is more severe pancreatitis.
Celiac plexus block is usually given in cancer related pain, not in acute pancreatitis to start with. Okay, that will be the last thing. And you said epidural. There are some concerns related to epidural as well, or no? Yes, Atik.
It can be option, sir. It can be option, sir. Only.
That you can use that epidural can be given if there is no coagulopathy, if there is no associated liver involvement, and the coagulation profile is okay, then epidural will be a good choice because it will give a good analgesia. Okay. Start with the simple things. Paracetamol. If there is no liver involvement, paracetamol is relatively safer one. Okay. Then what about why you are not saying fentanyl in ICU?
I told other drugs, class of drugs of opioids, but you haven't listened that, sir.
What other drugs of
Like fentanyl, fentanyl, etc., sir.
Okay.
And
Okay. So fentanyl infusion you can give. Okay. What about if the patient is, for example, you can say also that the management, the pain management will also be related to whether the patient is intubated or the patient is awake, because some of the medications you can give when patient is mechanically ventilated, like for example, you can give dexmedetomidine in awake patient as well. Dexmedetomidine will give a very good analgesia. Okay. And some other modalities you can use. But morphine or epidural are superior, or this one, celiac plexus block, are superior, but has problems associated with it. So whenever you are telling these things, you will say that because celiac plexus block, if patient is already for example, coagulopathy, you will not try to do, because it's you are giving celiac plexus block very near to aorta. So if there is some problem, it can bleed like anything. If the patient is not hemodynamically stable, would you like to give celiac plexus block to control the pain? Not at all. Celiac plexus block causes severe hypotension. Am I right?
right, right.
Okay. So you see, I'm not saying that you are telling wrong thing, but you are using in a wrong way, and this can lead to very dangerous sequelae. That's why I am stopping you. When you are again then if they are asking you about the pain relief, you will be saying, I will be evaluating the patient, and my plan, analgesia plan, will be according to the patient clinical and hemodynamic situation and coagulopathy, okay, and liver involvement, because these factors will be decide me which thing I can use and which thing I cannot use. Okay. Yes, pain management is a big challenge, but I have to use my things according to the scenario. Morphine it will be a good choice if there is no problem in the liver. If there is no coagulopathy, placing an epidural and controlling it will be a good choice, but I have to manage the anticoagulants use. Okay, anticoagulants use which may be needed in such patients who are on mechanical ventilation. That's why epidural is not a very safe thing when patient is having just tell me one thing. Is it a safe recommendation to give anticoagulants while the patient is having epidural in situ?
No, sir.
There are more chances of epidural hematoma. So just tell me one thing. Will be your answer be complete if you don't tell this thing to examiner? He will be making a mind that he is not a safe anesthetist. Okay. So that's what I want to tell you, that this thing you will not find in book, I guarantee you. And this thing they want to listen in the exam. They will be written morphine. They will not telling you the tits and bits. They will be written epidural. They will not tell you the tits and bits. So in the exam, this is the failure point. If you are telling everything, you have started with Renson and Glasgow and whatever you want to tell, and when you come the management, they saw you that you are telling something unsafe. They will catch you. This is the problem. So this is a message for everyone, that try not. It's not a matter of becoming hero. It's matter of becoming safe, which marks you in the exam. That's it. Okay. So fluid management, regarding fluid management, the same principles will be there. If the patient is hemodynamically unstable, you can have intra-arterial blood pressure monitoring to have a better control on hemodynamics. Maybe patient may be needing vasopressors. Okay. So your fluid choice will be according to that thing as well. Number one. Number two, fluid choice will be also because some of the patients will still having enteral nutrition, but some people may be oral free, like NPO. So in that scenario, you cannot give enteral nutrition. Okay. If there is some involvement of gastrointestinal system in the way that you are unable to give the enteral feed. Okay. In that scenario, your fluid will be according to the parenteral nutrition you are giving. Okay. So you will be using the approach which is needed for parenteral nutrition. You can say that it is better to use peripheral parenteral nutrition, which have less complication as compared to while using central lines. Okay, so these are the things which you can say. Otherwise, all other things will be according to the electrolytes which are used. Which are being disturbed. If there is no acidosis and patient is hypotensive, or even in hypotension, normal saline. Later on for maintenance, you can use ringer lactate. You will be using the transfusion triggers as you use in ICU for the blood and blood products management. Okay, I hope we have covered it. Ji Atik bhai, anything else?
I think so, sir. You are beautifully covered everything.
Okay, so I hope you understand my point of view, that please just try to be methodical. Okay, because this question is frequently asked in the exam. So there will be, first question will be, what is acute pancreatitis? It can be acute, it can be chronic. It has certain causes. Usually it's not an isolated finding. Usually it is caused by something else, maybe surgical, maybe infective, maybe traumatic, maybe alcoholic, maybe obstructive, like this related to biliary tree. So first thing will be to identify the problems in that patient's severity status. Okay, there will be the main diagnosis will be clinically and supported by further investigations, enzymes and this everything. And then you will be focusing your management will be general principles will be the supportive management with airway, breathing, circulation, use of the things which are needed for the treatment, like any specific surgical indication. Otherwise, some tests are diagnostic as well as therapeutic, like ERCP, MRCP. Okay, and then all the fast hug which we use, if patient is intubated or if patient is in ICU, this patient should be shifted in ICU for care, and the rest of the management will be general supporting, feeding and airway management and analgesia or sedation and the formula which we use. Okay, so this is how you have to answer and tackle the questions which may be asked for pancreatitis. And in this topic, we have also covered some of the aspects of the severity, assessment of severity in the patient with in ICU. Okay, Rabia?
Yes, sir, and organ support and also prevention, early recognition and prevention of the complication and their management.
Yes, so this patient can go in sepsis, this patient can go in ARDS, this patient can go in DIC, this patient can go in coagulopathy, this patient can go in septic shock. Okay, so these things will be there in your background, and whatever management you will be giving will be targeting these complications. There is high chance of ARDS, there is high chance of pleural effusion, there is high chance of severe pain and sequelae because of pain. The stress response may lead to precipitation of cardiac status of the patient. Okay, so like just thromboprophylaxis, nutritional support. Actually, why they are asking this topic? Because it's a topic in which they can ask all the aspects of ICU. All the aspects of ICU, yes, diabetes or any other comorbidity. Okay, so just I hope that it is clear to everyone. And now we will go to our next topic. The things related to COVID patient. So again, the COVID patient, they will ask you, definitely, they will ask you in certain things. If they are asking you the management of COVID patient in ICU, this is actually, thing is that it is nothing special science, because up till now, they are just trying to discover the exact treatment. There is no specific treatment for it. The general antivirals they are using, they are there is no specific thing which is labeled as the management for COVID. So rest of the things will be related to all the general ICU care, the problems related to ventilation, the problems related to thrombosis, because there is high risk of thrombotic events in patient with the COVID. There are chances of patient in ARDS, VAP, all the package deal octopus-like stuff which we face in any ICU patient. So there is nothing specific of it. Yes, there will be something that there will be respiratory features, and then you have to do some workup related to DIC or related to just this FDPs, and so you will be your thrombotic and anticoagulants will be according to that level. They have made certain criteria for that. So this is related to specifically to the treatment. There is nothing specific. The same care of ARDS, the same management of ventilator associated pneumonia, the same management of sepsis, the same general care which is there for every patient, and the use of antivirals. This is all about COVID. Okay, the most important thing is prevention of the transmission and care of the healthcare workers who are taking care of the patient. Okay, so this is this is the main theme. So our main focus will be towards the preventive measures. Okay, so who will tell? Just raise the hand. Who will tell about this topic? How to prevent transmission? Asim bhai, would you like to say something?
Yes, sir. Assalamualaikum.
Walaikum assalam. Yes, you just focus how like my question, because this will be asked in talks, OSCE exam, or this can ask in the table viva. They will be asking you how would you prevent transmission of COVID to the healthcare workers and among the patients, if the patient is in ICU, for example, or if you are dealing a patient with COVID positive or suspected COVID, and you are giving anesthesia, both for regional anesthesia, both for general anesthesia and ICU. What will be the general principles for it? Okay.
Yes, so the general principles we started from the clinic where the patient is scanned. There is one respiratory triage in any hospital, which is very far away from the normal outpatient emergency. And then they are doing there they have a barrier from the
Asim bhai,
patient to
sorry.
patient.
You are absolutely right, but actually our domain starts related to OR and ICU.
Okay.
You are not telling wrong thing, but again, as I stop Atik bhai as well, I am stopping you as well. The same mistake you are doing. Try to tell, because you don't have time for long stories. Okay.
Okay. So for the ICU or OR, we have to do a barrier nursing. The patient should, whenever the COVID patient is suspected or positive for COVID, should be isolated from the another patient and from the other staff of the OR also. We have to close the doors for the entry of the patient, and for ICU there are certain cubicles for the ICU with the negative pressure, and there are dedicated staff for that patient, which have their own safety. They have hazmat and this N95 mask of their tested sizes, and then for this patient we have to take it because these patients are usually in respiratory distress, so we have to put a certain oxygenation for
just
them.
a second, Asim bhai, sorry. Again you are jumping from one topic to other topic. We are only focusing because we have to be very specific. Like you have told number of things. Try to be focusing on the prevention first. Like you tell 995. Okay. You should be telling about the doning and doping. That's what the focus of this question which I've asked you. What are the things, and what about negative pressure room? What about bed-to-bed nursing? Okay.
Yes, I told about this dedicated staff for bed-to-bed. There should be a dedicated staff for this COVID patient.
Yes.
And the room should be a negative pressure room.
Okay.
And for the intubation for these patients, we have to be very specific for this.
Just a second. Okay, just hold on for airway management as well, because it needs more detail. General care, is anything missing? Donning carefully in a separate area. This is one thing. and a dedicated bed-to-bed nurse. Okay. Preferably the nurses or staff should be vaccinated. This will be also a logical answer at these days. Okay. And then negative pressure room and 95 mask. If it is not fit, that this they can ask you, what is this respirator? What is it? How it works?
Which one? The high flow, is it?
No. The respirator which you are putting on your face.
Respirator. Okay.
What is it?
Okay. This is for the non-vaccinated or unfit. If there is no fitting N95 for that healthcare worker, so they are putting this N95 mask. There is a suction from the air, and there is a certain filters which will, I think, less than 2 micron or something.
What is the abbreviation? What is the abbreviation of this word? The word, even I forgot this name. What is the name of this thing which we are, this box which we are wearing?
This is
anyone?
Which box, sir?
Which we are just wearing, yeah. This space uniform which we are wearing if we are going to the patient.
Bunny suit. It's a bunny suit.
No, this is hazmat.
But that is not recommended for COVID. You're talking about the negative suction type of suit.
No. This I am talking about this respirator, which the
respirator,
this machine which is giving oxygen. Asim bhai, you know about it. I'm not sure in Pakistan it's available. It should be available, I think, in Pakistan as well. The one which we are using it. What is that called? Oh, you see, this is sometimes some things slip out of the mind because I'm not working in ICU. I'm working in anesthesia, so I forgot its name.
Pepper, sir.
Pepper. Okay, so what pepper? What does it stand for? Positive or purified air?
Purified.
If someone can Google the name, please. Because this one I was asking you. Okay. So the principle of pepper is just like it is taking the air, purifying it, and giving it to you.
Yes.
Okay. So this is, but the problem is that during doffing and donning, there can be chances of transmission. Okay. So you have to be very careful about it. And we are covering
powered air purifying respirators.
Again, please.
Powered air purifying respirators.
Okay.
PAPR.
Okay, so I hope you understand this. You don't forget this name because they can ask you. Okay, this name should be known to you. So this is the thing. Again, I repeat: careful handling of the patient, N95 mask, shield, and this one negative pressure rooms. This doffing, donning. They will be asking you: is it a airborne or droplet? Droplet. And if it is in the very close proximity, then it becomes airborne or no?
It's both airborne and droplets.
Yes, droplet.
No, it is always droplet. It is aerosol only.
Aerosol only. But in the close, if you are very near, that it became airborne as well. Okay. If the
droplets are there. If a person sneezes or if a person coughs near you, the droplet will remain in the air for some time. So it's carried with that droplet for some time in the air.
No, but that's what I'm telling you, that usually its transmission is through droplet. Can be transmitted when you have, for example, if you were there, you put your hands and now you have come home and you touch your family member, or it can be transmitted like that. Okay. So this is one way. I'm telling something else. I'm telling that if it is in close proximity where there is very high viral load, then it can be considered as airborne. Okay, so it is through droplet, but if it is in we are in close proximity, we are in a place where there is very high viral load, then it became airborne as well. So that's just, I'm not very expert in it, but that's what I have the understanding for it. Okay, so now come to the question, Asim bhai. Next question is how to deal the airway in a patient with positive COVID. There will be certain the recommendations for it. Yes.
So for certain recommendation, this patient should be took before an outline, or we have to take a ABG for this patient to see what is the level of hypoxia. And these patients are
Again,
usually on
Atiq bhai,
hypo.
Asim bhai, sorry. Again, you are
Yes, sir.
doing the same mistake of Atiq bhai. Please. The question is what precautions we will be taking in the patient with managing the airway of the patient with COVID positive. Your answer is not wrong, but you finish this discussion in very simple way that of course you will be identifying the patient who needs airway management. Okay. In that way, you will be telling all the things which you are trying to tell. You are doing because you see this will irritate the examiner. He doesn't want to know ask you this thing. He can ask you, but at that point of time, he is asking you what are the precautions you should be taking when you are doing airway management of a patient with COVID positive. So this is not the answer what you are telling. Okay. Please again start.
May I add?
I'm sorry.
May I?
The next question I will ask you. Asim, please try. Just give.
Okay. So the precaution we will take is for intubation we have to take a controlled environment with the negative pressure of room, and with the suction, with the ambo should be the high flow nasal or oxygen should be attached till the patient is intubated. We will not take this off because of hypoxia for this patient. And we have to do a rapid sequence induction for this patient, and because this patient are hypoxic, so we have to do a rapid sequence. And for intubation we have to do
Atiq bhai, sorry, Asim bhai, you are again telling something which you are not supposed to tell. If you use this word, your patient is hypoxic and you are doing a rapid sequence induction, does it make a very nice impression? You understand my point?
Okay.
You see, why are you telling the thing which is not needed? What is the question? What precautions you need? You should be telling at this time that you will be trying to minimize the exposure. Okay, so rapid sequence induction will be a better choice, and use of glidoscope or video laryngoscope, so that you are trying to be as away from the patient as much as possible. Try to have deep level of anesthesia so that patient does not cough. Use of some anti-saligogue before you do intubation, so that, or do the suctioning before you approach the patient. Okay, these are the things which are more important than what you are trying to tell. The patient is hypoxic, that's why I'm doing rapid sequence induction. He will catch your neck, believe me. This is not needed. Okay, because you are just poking him. The question is something else, you're answering something else. Okay, so rapid sequence induction you are doing in these patients for some other reason as well, that you don't want to ventilate the patient too much because it will increase the risk of transfer. Okay, a patient is already hypoxic, you cannot do anything. You are intubating the patient because patient is not responding to high flow nasal cannula, patient is not responding to any treatment, patient is not responding to CPAP or BiPAP, and now that's why you are intubating the patient. Am I right? So this question is finished. When they are asking you about the question about the transmission, try to figure out the words which are more related to transmission of the disease. Okay, I hope you are clear now. So suctioning, minimizing the time, proper use of the technique, which proper use of the barrier precautions, use of glidoscope or video laryngoscope, and rapid sequence induction, because that will be aiding your target. Okay, yes, if for example he is asking you that, for example, you are doing rapid sequence induction, patient may be hemodynamically unstable, then you can say that you will have to increase the support, because at that time this is also your priority. Okay, or you can go for other things. If there is a suspected difficult intubation, there will be other maneuvers for that one, fiber optic or whatever. Okay, But usually this will not be the domain of the question when they are asking you, because this is the hot burning topic all over the world. So this will be asked. This will be asked in talks. How will you prevent the transmission of disease to the healthcare worker, or among them, among the healthcare workers, and from one patient to other patient? This is what is the theme we are discussing at the moment. We are not discussing the management of the COVID patients actually. Okay. So is there anything else missed? Anyone wants to add? Zishan, now you can add, please.
Yes, sir. So there are two more things.
Yes.
Number one was the proper discussion and proper planning between the team, and the roles should be assigned before embarking in the procedure. Because when we are wearing the PPE, communication becomes very difficult. And then we also want to avoid any kind of
Confusion. Okay.
miscommunication or
And
any errors during that.
yes.
Secondly, when we pre-oxygenate the patient, the pre-oxygenation should be done with the tight seal on the mask with two-hand technique, and the other person should be bagging. With one hand on the Hudson mask is not usually a good technique, because it can the air leaks more
Okay,
from
fine.
that.
This is
So
very
during
good.
the
This is good.
Sure.
And
during the whole of the procedure, we
Mhm.
have to avoid any kind of aerosol, any kind of leakage in the circuit,
and minimizing the people who are there inside.
Yes. Yes.
Okay. And another thing I will add, because this is a controversy. Even high flow nasal cannula is associated with more transmission. CPAP is associated with more transmission. The better choice in that scenario is intubation, because this will cover a whole of the area, and minimum transmission is when the patient is intubated. But that is something else. Okay. That is something else, because we have to go gradually. We don't want to intubate all the patients. There is still no specific guidelines which are telling you should intubate or you shouldn't intubate. Some people say early intubation, some people try to escape from intubation. There is no, because we are just doing hit and trial. The patient who do decompensate is not responding to any bloody thing. Rather, in just a personal experience, that you will also accept this thing, that usually patient when the saturation is 85 or 86 and you are intubating, and when you are intubating, after that either there are high incidence of cardiac arrest, especially the patient is comorbid, or I have seen multiple times saturation even going further down. Okay, so that's what my little experience of COVID patient when I did last year in COVID ICU for some time. Okay, so that is something else. So anyone wants to add to this discussion related to COVID transmission and everything? Atiq bhai, would you like to say something? Anything?
Yes, sir, two things, sir, I would like. Sir,
yes.
If we have to pass having a larger diameter like 7 to 8 in female and 8 to 9 in male, so that the ventilation should be easier. And another thing was that, sir, because of this, we have to confirm with the with capnography, sir. And sir, we have to record each and everything, sir. And then another thing that, sir, we have to use everything disposable, so that the equipment should be destroyed, decontaminated after using it.
Okay, this is actually nothing specific. Number one, I would be asking you one thing. What is the problem in usual COVID pneumonia? Is it the problems related to static compliance or dynamic compliance in the form of plateau pressure or peak airway pressure? What is the more significant problem?
Sir, in dynamic compliance, sir.
No, wrong. Static compliance, because static compliance is related to plateau pressures, and all of our story of lower respiratory tract infections, VAP, ARDS, is not hanging towards peak and peak pressures. It is towards static compliance and plateau pressures. Okay, and it has nothing to do with the size of endotracheal tube. So I don't think so. It is a very valid, a very good point.
Sir, it is written in sir COVID SOP, sir. That's why I told.
Explain it in scientific way. How will it affect?
Sir, in female, the internal
Yeah.
diameter should.
Tell me. No. Oh, I accept. I understand what you are trying to say. But tell me,
with this subglottic suction port, sir. With subglottic suction
subglottic
port.
suction port is something else, Dr. Atik. Subglottic suction
Sir,
port is
I'm
always.
telling that we, sir, intubate the patient with the larger diameter because with this subglottic suction port, so that the to avoid the web as well.
No. Please be clear about this thing. Subglottic suctioning is something else. Subglottic suctioning is even available in size 5 tube. Okay, so that's not a problem. Subglottic suctioning is something else. It can be there in any tube. It has nothing to do with the diameter. This is number one. Okay. Number two, what you are trying to tell that we should be using higher diameter. This is for increased airflow. Okay, fine. But this is not giving any benefit in patients with the, just explain the benefit, because the problems in any patient, in
Sir,
any
because
ICU
of the blockage as well, sir, because of the blockage.
Blockage. Okay, tell me scientific reason. Again, you are going towards the peak. I'm telling you that the things related to lower respiratory tract infections, related to this one ARDS, pneumonia, this is mainly related to plateau pressures and static compliance, which has nothing to do with the size of the tube or even blockade of the tube. This is making problem in the patients with obstructive lung disease, okay, where there is problems related to peak pressures, okay, or problems related to dynamic compliance. Okay, so this has nothing to do with management of patient with ARDS. Have you heard about it before? If you have heard it, explain to me. Otherwise, please don't say it. If anyone on the forum can explain, give an explanation in a better way what I have done, or disagree to me, I will be very happy. Tayyaba, Rabia.
No, sir, yes, sir. You're perfectly right. I think he must be talking about the inline suction ready. You must be having a tube with a subglottic suction or inline suction ready just to minimize the aerosol spread. This is the aim behind the.
That is something
Yes,
else. And
but there is no role of increased diameter of ETT used in the COVID or in any other patients.
yes,
In this scenario, at
in
least.
this scenario, that one explanation I will give. I wanted him to say, but he did not tell. Atik bhai, I'm giving you another chance. Your answer can be justified if you give that explanation.
The role of endotracheal diameter is the flow. That means the turbulent or laminar flow.
Just let him. Just give. I'm giving him another chance. Atik bhai, please try to explain. If you are giving a higher diameter tube, it has one relationship related to the spread of the infection. In that way, you can explain. Give you the explanation. Atik bhai, can you hear?
Sir, sorry, मेरी call आ गई थी. Oh,
my question is that there is a relationship between the higher diameter of the tube and prevention of the spread. Can you rethink that? What is, because the explanation which you are giving is not valid. Plateau pressure is the one, so that is wrong. Number one, but still you can defend this statement by using the word which maybe you recall now. Whenever there is appropriate size tube and proper seal, okay, then the chances of transmission of the infection will be reduced. So that makes sense. Okay, you should not be using the smaller diameter tube which have leaks, which is there for any patient with the mechanical ventilation. If there is leak, there are chances of aspiration. So you are using the appropriate size tube with subglottic suctioning. This is part of WAP bundle. This is for any patient, not specifically for COVID. Am I right?
Sir, you are right, sir.
Thank you very much. That's what I want you to learn, that don't try to present a beautiful rose and that the examiner will make that rose cauliflower for you. Okay?
Sir.
Good example.
Okay, just try to just say assalamu alaikum to the examiner. Don't try to give flower. You know, I will tell you something that when I was in medical college, one of our community, a very funny character, he just tried to worn a badge of his community on the front of his pocket, because he came to know the examiner is from his community. Okay. And you will not believe that that examiner, he was examiner, okay, he was like father. He twisted his neck like anything in the exam. He did not fail him, but he made that, they made him pay for the fancy thing he was trying to do. Okay. Okay.
Okay,
Okay.
sir.
Okay. So
One thing more, sir.
yes.
We should be having we should also, before intubating the patient, we should give fluid.
Your voice is distorted. Yes, we should be optimizing the patient. That is related to the care of the patient. Okay, we should be optimizing the hemodynamic status of the patient. If the patient is suspected, we are doing rapid sequence induction. We can use the medications in a smaller dose. You can use the medications which are not disturbing the hemodynamics. These are the things which are there for the COVID care. Okay, so that is something else. Okay, so what else is left for us in the agenda?
Also, one thing, sir, I want to add, also prepare for difficult intubation as well in the
Yes,
COVID
of
patient.
course, of
So you
course.
might need help.
Of course, you should having the all, because that's what I'm telling you, that I have seen one of the person intubating in front of me, and he gave medications not in the way he should be giving, and the patient went into cardiac, and in front of me, I was just unable to do anything because these patients are already sympathetically discharged. They have high sympathetic, even ketamine can cause problems. So you have to be very careful. That's why it is better if you can take, you can say, if you are telling these things, you can say that you should try to maintain the hemodynamics at that time with some inotropic or vasopressor support, and you can take arterial line to be on the safe side. Okay. So I think this is what they can ask you for COVID patient. Rest of the things are related to ARDS or VAP or general ICU care. And I think what else is left? Any other what was the
Sir,
other
they
topic?
have asked, sir, should be, they have asked me how to anesthetize, what are the anesthetic concerns when the patient is coming with emergency surgery and COVID positive patient.
Same thing.
What precaution?
Same thing.
What precaution you would? Okay.
Same thing which we have discussed. You see, the gravity of the disease will be variable in maybe COVID patient, the pregnant patient is having nothing. Okay, so the preoperative status will be important. That what is the preoperative hemodynamic and respiratory and FiO2 requirement of the patient, number one. Number two, any end organ damage or anything related to it. Lung protective strategies, Jamil, only if there is some problem in the lung. If the patient is okay, why to do lung protective strategies? If the patient
no, sorry, actually I was answering another person that
okay, fine. So this will be the thing, and post-operative HDU monitoring can be there if you want, if you are expecting anything. You see, if the patient is normal, patient is not having end organ damage by COVID at that time, actually you have to deal it like a normal patient, unless only in addition to the barrier precautions which you are taking. Okay. Yes, you can avoid GA because it will reduce the airway manipulation. This is a very valid point. You can go for the regional anesthesia if it's possible. Otherwise, the same principles, same careful principles, prevention of the transmission. And if the patient is borderline, then you will be anticipating everything, and you will be doing the lung protective strategies, and you will be taking care of all the fluid management, hemodynamic management, and that's it. Okay. So I don't have very good concept of this needle stick injury. Okay, but I will just try to tell or discuss. We will together what happens. Needle stick injury can be in two scenarios. One will be that if the patient is known case of some disease, or the patient have unknown status. So the things will be a little bit different. If you have, in either case, you will just try to squeeze and wash the area with soap and disinfectant or sterilizing agent, okay? And you will just try to squeeze as much blood as possible, so that you are trying to decrease the viral load if it is if it is transmitted, okay? So this is one common thing, even if it is known positive or unknown positive. If unknown positive, you will track the patient, you will take the record numbers, you will inform the department of infection control, who will be guiding you to do further for that thing. And maybe you will be doing the viral profile for that patient, okay? Hepatitis B, hepatitis C, HIV, or anything you are suspecting. So this will be one thing. If, for example, the other way, if the patient is known positive, what will be doing? You will be
Known positive for
Sir, in the
which disease?
known positive for, okay, you can go one by one.
If the patient is known positive for hepatitis B, then we will go for the hepatitis B immunoglobulins. If the
Just a
patient
second.
is
Just a second. If the doctor is working there, if you are talking of hepatitis B, would you like to comment that whether what is the status of the patient immunization?
Doctor's immunization.
Okay, so maybe doctor is already immune, and the doctor is having. You can do the antibody titers for that person. Okay, so that will be telling you how much bodyguards, how much your army is working in what way. Okay, so you will be make a habit. This is not treated by you. So you can say that I will be consulting the pathologist, virologist, or the team which is specialized in that one, and I will be taking help from them. Okay, and the option will be like that. Like they can consider some antivirals. There can be use of immunoglobulins according to the viral load. Would they like to identify the markers? Would like to do hepatitis B surface antigen or core antigen or something like that, or no?
Yes, sir.
Yes, sir. That is done to check the immunization status as well as the infectious status.
Listen, Zishan, we have used the wrong word. Immunization status is through the antibodies, not through the viral load. Okay.
Yes, sir.
Viral load is something else. One friend is in the blood now. Maybe you will find his head, you will find his toe, you will find his body. So it's like that. Yes. And you can identify the marker, the whole virus. So that is not related to immunization. That is related to viral load. Okay.
Yes.
Immunization status is through the antibody titers. How much antibody titers you have? Okay. So this is, I think, for hepatitis B, they will consider some antivirals. I don't know the names of antivirals which is being used. You can just read about it, but the concept is like that. The concept is that you will be having infected patient or an unknown status. You will have a patient immunized or unimmunized. Okay, so there will be a little bit difference in those patients, but the general principle will be the same. You will be tracking the patient. You see, if you don't know, I don't know anything about this topic. I have not read even in my exam. Okay, whatever knowledge I am telling you, it's just the concept which I have. So even if you tell this one, they will not fail in the exam. I can guarantee you. Even if you are not able to tell the name of antivirals, there is a chance you will be on 50-50. If you don't have any problem, because you are not failed on the basis of one answer, one question, one scenario. They are creating, but I think we have our very senior examiner here. He will agree to my point. He's already left. Dr. Akhtar Waheed. The examiner, I think, when the patient, the candidate is sitting on the chair, by the look, believe me, he will be able to pick whether this gentleman or lady will be able to answer my questions or not. They are very experienced. They know they know you your face, and then that's what I did not pick it. I only picked it when I just had some mock exams, because I'm not an examiner. But when I saw the the people, believe me, there is something written on their face, and I do whatever effort I'm doing, I'm just trying to make you, I'm not using that word online, okay? And I don't want you to look like that person which I'm talking, okay? So, so just try to be confident, try to be very have eye contact with the examiner. And even if you don't know a topic, you can still have some smart answers, which I am trying to do. Okay. So what about now a hepatitis C and HIV?
So for HIV, we give a triple regime. There are 3 antivirals combined given for 4 weeks, I think. Correct me if I'm wrong.
Okay.
I don't remember their names, and I don't want to remember their names. But there were 3 antivirals, and they are given for 4 weeks.
Rabia, would you like to say something about this topic?
So if I start it from the very start,
okay.
Whenever we are doing a procedure and we encounter a needle stick injury, first of all, we have to call for help. We have to call someone to take over the procedure because we will have to leave at once. Then we'll doff our gloves and we'll put our hand beneath running tap water, plain tap water, and we'll keep it under running water. No, sir, squeeze. Somewhere I read the squeezing is not allowed. Another place it was written, so I'm not going there, not mentioning any kind. So just running under running tap water, we keep it for at least 5 minutes. And then after that, we have to inform our in charge, whoever is the lead in the head of department, and then we have to inform the our infectious disease department also. Then after that, we first of all look to the charts of the patient and we confirm if the patient is already has any kind of disease or not, whether he was already tested before the procedure or not. If we get the confirmations that someone is positive, or we get the confirmations that he was tested for all these diseases and there's nothing there, then we just wait and see. Nothing else has to be done. But if the patient's status is unknown, the patient was then first of all, we have to test ourselves also, the current status of our own infectious status. And then after confirmation with the patient, after counseling the patient that this exposure has happened already and we want to test you. After his consent, we will test him for all the mentioned diseases like HIV, hepatitis B, and hepatitis C mostly. So this is the algorithm.
This is
and then after that.
Okay. Anything anyone wants to add to it, because I have to wind up. It's we are already getting late. Anything else to be told or discussed about this topic? What are the universal
precautions? General precautions. Yes, sir. General precautions.
What are the universal precautions
to address? Yes, just to reduce the risk of infections, you must be using the universal precautions when performing any exposure-prone procedures. Like you must be having glove, mask, and goggles. Also cover if you have any open skin lesions, then you should cover up that skin lesions. Avoid mouth-to-mouth ventilation is also included in the universal precautions. Also try to use HME filters as much as you can. Or make sure to have hepatitis B vaccination of all the healthcare workers. And then if exposure happens, an exposure protection plan, and then you must be having a management plan after this.
What is difference between decontamination and sterilization?
The procedure which we follow for
no, what is difference between I'm not talking about, again you are doing the same thing. What is difference between decontamination and sterilization? This is the answer to how it is to do it. You can tell it in the same answer, but to start with, what is difference between decontamination and sterilization?
Decontamination is the removal of the the dirty stuff from the instruments, and it's by washing, brushing.
Okay, so I will add one more word to it: disinfection. Sorry, I actually decontamination by mistake. I said it is disinfection because contamination is something else. Discontamination is to remove cleaning. It's sort of cleaning. Okay, So what is
Yes,
difference between
sir.
disinfection and sterilization? There is one difference. Jameel,
Disinfection. Sir, sorry.
you have no margin not to answer this question. I will kill you.
No, disinfection, sir, removal of the vegetative form of the bacteria, except spores.
Yes, thank you very much.
Spores are other
In
forms.
sterilization,
And
it's everything.
sterilization, yes, everything.
Okay, so sterilization is even spores, and only thing which is resistant to sterilization as well is.
Clostridium tetani.
Thank you very much. What are you telling? No, it's not Clostridium tetani. Go beyond that thing something.
CJ disease.
CJ disease. Thank you.
Yeah. Jacob.
To try not to use the abbreviations, but there are innocent people who don't know about it. Prions disease, or if you are telling Creutzfeldt-Jacobs disease. Okay, Creutzfeldt-Jacobs disease is a spongiform disease created because of prions, proteins, and from minor things that it can be lead to life-threatening neuritis. Okay.
They cause like a cystic disease in the CNS or spongiform disease in the our CNS.
Okay, Jamil, sorry, by mistake, you unmute, please. Unmute, please. By mistake, I pressed yes.
So prions are the small particles of proteins or peptides, and it can cause the spongy form or spongy-like form disease of the CNS.
Yes. Okay, so some other words they can ask you. What is pasteurization? Bacterial spores. It's a type of disinfection. Okay.
Pasteurization is disinfection, but at low temperature with long time.
High temperature.
High temperature for long time.
Sorry, high temperature, but not boiling, means 60 to 80.
Yes.
70 degrees for 30 minutes and done mostly for the food items and beverages.
Yes.
Yeah. 60 to
Okay.
80
So what are other ways to do the disinfection?
Sir, they are done with chemical measures like alcohol, carbonium compounds, phenols,
ultraviolet rays,
chlorhexidine, acetic acids, and
this is
glutaldehyde.
Yes, glutaldehyde, because you can differentiate in two by the surface or for the instruments. This is a little bit different. That there you are dealing with the
levels of disinfection, no? Low level of disinfection, intermediate, and then high level.
Yeah, and so you should be knowing the. I'm not expert in those, but there are certain names you should be knowing. There is alcohol, there is hydrogen peroxide. Okay, so there are different types which there, and sterilization is through.
It's through by physical, chemical means and by gaseous mean.
Like steam, by chemicals like glutaldehyde, this one ethylene oxide,
phenol,
okay,
halogen. Yes.
Okay, and another thing which they will be asking you, what is difference between critical and non-critical items?
non-critical items actually they don't pierce the skin or mucous membrane. And critical item, they have direct contact to the risk of penetration to the skin or mucous membrane.
What about laryngoscope? Is it critical or non-critical?
It's like we consider as a critical.
No, it's semi-critical.
It's definitely not
with the mucous membrane.
It's not penetrating the membrane, but we deal we do the sterilization, not
actually the items which are with the skin are non-critical, which are with mucous membrane is semi-critical. Okay, and the ones which are dealing with the operation site, or so that is critical items. Okay.
Yeah, so, it's including semi-critical, but sir, we deal it as a critical because the blade of the laryngoscope should be sterilized, not only just like in a non-critical, we just remove with alcohol swab or something else, just wash. No, we have to deal it because there is risk of also blood contact with the blade of the laryngoscope.
Okay. Okay, so one of the things I'm not very perfect again in it. How to the concept is that to use disposable. Okay, so that's why we should be using the disposable items. Even now there are disposable laryngoscope blades which they are using. Okay, so even for what else is left? So even laryngoscope blades are available, which are disposable, one use. Okay, so the endotracheal tubes are disposable. LMAs before they used to do, and they used to use it up to 39 times. This is an MCQ which they can ask you. It's not related to modern anesthesia anywhere. I don't think so. Okay, and what about the bougies?
So ideally, these should also be
Which is
disposable.
non-critical. You know, we
Jamil,
use
if you are saying this non-critical, then why are you saying laryngoscope critical?
bougie. Actually, sir, the bougie is do not
bougie
penetrate.
Bougie can penetrate. If you are using, it can penetrate. Okay.
Depends upon the operator. Yes.
Of course, depend on the operator. Okay, so it's like that. Okay, so one thing they can ask you about how to sterilize this fiber optic. By the way, fiber optics are also available now. Wrong. This one. Disposable. Okay. So I think it is. Do anyone knows about it?
Disinfected with glutaldehyde solution.
Glutaldehyde solution, because I think it's the same like the endoscopes which other people are using. Am I right?
Yes, sir. Same.
Yes. So what else? Anything else left?
Sir, one thing I want to
yes,
add.
yes.
Sir, once we used to use the term universal precaution, but now it is replaced with the standard precautions.
Very good. Thank you.
Sir, with the universal precaution, there was a concept of like protection from the contamination from the blood and the fluids. But in standard precautions, there is a concept of precaution from the airborne droplet and contact. Both all of the routes. So this is the term which is being replaced.
Okay.
And covering all the aspects of transmission of the.
Okay. Okay. You know, one more word I forgot to tell you is the use of HEPA filters. Okay. The HEPA filters are being used in also for the in the ventilators, in the ICU ventilators. Okay. So HEPA filter are also one of the things to prevent if negative pressure is not available. Okay. So they have used everything, gamma radiation. And there is one thing which I'm just looking at the article. There is one thing which I don't know, gas plasma sterilization. What is it? I have no idea about it. Atik bhai, would you like to say something? Atik bhai is here or left?
Yes, sir, I'm here, but sir, I was having patient. I was busy.
No problem. No problem. Now we want to add something.
Sir, they have asked me in Viva about HIV, sir. HIV patient are there, and how will you intubate, and if the renal stick injury occurred, then what would your how much?
Atik bhai, almost we have discussed this thing. There is a separate article for HIV. Let me find it. We can before that, do you know about this gas plasma sterilization? Anyone knows about it? Because this is the word.
Is it same as ethylene oxide?
I sir have a small idea, but I think in glass plasma sterilization gas, there is low temperature. I think it's not high temperature. They go to minimum, you know, like minus like 120, like these very low temperature. Then they sterilize the things.
Okay, just
I listen about it, but I'm not sure.
They will ask you if there is needle in stick. which has the highest incidence of transmission?
Hepatitis B, sir.
And what about HIV?
Sir, its incidence is
You should be knowing it because this question just came to strike to my mind. I'm not sure where because I don't know it, but you should be knowing that if there is needle stick injury, what are the chances of transmission in each disease? Okay, and I think
HIV is 0.3%,
yes,
3% for hepatitis C, and 30% for hepatitis B.
okay, thank you. This is how you should be doing it. Okay, and the question which about HIV. Atik bhai, what do you think should be the care? Anyone wants to say something? Because actually, again, there is the same standard precautions as per Rabia. Standard precautions should be monitored. Okay, and because these patients are at risk of infection, so you have to protect them as well. Okay, and their transmission with the secretions, is it possible through secretions?
Secretions and
it is
blood
possible.
contact.
It is possible. Blood, semen, vaginal cells, CSF, pericardial fluid, breast milk, etc. That they are responsible for the risk for the HIV, sir.
Okay. So I think among the top will be, of course, the needle stick. Okay, and among the secretions, I'm not sure about secretions. I don't think so.
Vaginal secretion, sir.
Okay.
Breast milk,
Related to anesthesia.
breast milk.
Okay, what about like saliva?
Sir, yeah, of course, saliva as well, sir.
Okay.
But saliva with density, saliva with more density, sir.
Okay, because
saliva is less risky than blood and etc., sir.
Okay.
But it can.
Okay. So it is more related to like blood, okay, and more related to like anal sex rather than other, because there are more chances of trauma because it transmit again through the this one what is that, the broken skin. Okay, so I have just tried to see it. According to CDC, HIV is not spread by tears, sweat, coughing, or sneezing. What does it mean? Sexual intercourse through vagina, rectum, or penile tissues, direct injection with HIV contaminated drugs, needles, syringes, blood, or blood products. Okay, so I have just opened it. That's what I was thinking, that I don't think so it is, because if it is through secretions like that, then we should not be even touching them, and there is no contraindication to touch the HIV patients. Okay, it is through the broken skin, through sexual intercourse, because there are more chances of having this thing. And as you were telling, this breast milk, I think there is transmission through breast milk as well, but it is not through coughing, sneezing, sweating, or tears. Okay, just reconfirm it. Okay. Okay, so I think we have enough time. We have invested. I have tried to cover these topics in which I am actually not very strong. This infection control and infectious disease, I'm. And actually, this is one of the reasons is that we are not working in ICU, and some of the things in Saudi Arabia, ICU and anesthesia is totally separate, and I have not worked in ICU since 2014. Only last year I worked in some time in COVID ICU. Otherwise, I'm not dealing with COVID with ICU patients. So I'm always lag behind in the knowledge related to ICU. Okay, but the basic concept remains the same. Okay, so I hope Sir, Dr. Akhtar Wahid Khan, sir, would you like to speak something? Your mic is, luckily your mic is unmute at the moment. We can hear you, sir.
You can't hear me. Can you
Sir,
hear me now?
Yes, we can hear you. Please. Sir, Dr. Akhtar Wahid is one of our legend professor from Pakistan. He is a convener in our College of Physician Surgeons, and it's honor for him to be with us. Yes, sir.
Well, if I start with the pancreatitis, in fact, when you started pancreatitis, I was myself a patient of pancreatitis,
Okay.
and you were emphasizing on the signs and symptoms. And in fact, when I went to the hospital after breakfast, and the first thing which I felt abnormal after reaching hospital is epigastric pain.
Yes.
The physician there, the general physician, he took me straight away to the ultrasound. And with the ultrasound, the diagnosis was that my pancreas, the head of the pancreas was solid.
Yes.
Then all the, whatever you described, everything, well, some of the things were not missing, were missing, but I was admitted in the intensive care unit of my hospital, and naturally, no nausea, no vomiting, nothing like that. But I think you perhaps avoid oral intake and other things
Yes.
in the initial period, because here they asked me not to take anything. They started a IV infusion, and of course I was given something for pain relief and everything. And the nutritionist saw me the next day, same day rather, and I was not given much to eat, but the final confirmation, one of your participants talked about the CT scan. Yes, I was sent for CT scan, and the diagnosis was there confirmed. So I had ultrasound and the CT scan, and of course, all the other things which you have mentioned about the blood count, everything was normal, except that the ESR was raised, had gone up. So that's what I can remember. It is, I think, about 6-7 years ago. And we did have the RCP, a very famous radiology unit here. The radiologist was trained in America. He's no more with us now. Advanced Radiology Clinic. He did that. And another thing which I can tell you, the supportive test, what you call the serum enzymes, it was raised, and then after some time it came down. So probably they suspected there was some stone, gallstone, or the stone in the pancreatic duct or something. But the enzymes was there. Because of that the enzymes level was raised. But then subsequently, of course, in the radiology clinic, they did my MRCP and everything was clear. After that, of course, I have become very conscious of it now, but I never had that type of pain. And the first thing that what you mentioned about, I was listening very carefully. You mentioned about ultrasound, and the two ladies also mentioned, especially the first one, second one who came. And the Atiq Bhai also mentioned, Jamil Bhai also mentioned everybody. I was listening. I was trying to retain as much as I can, and so that's it. And what was the second topic you discussed?
Sir, we discussed about COVID transmission, and because this will be a burning topic, and it's being asked in almost all the exams that are being done now.
I heard all about it. what you said. And why straight away clinical monitoring is very important. And ABC, as you said, is very right. But in the initial period, you can get a very good idea about if you just know the saturation, you know the respiratory rate, and you also see the type of respiration. Yeah, you can get a very idea. You have a clear indication what to do now to support the ventilation. And when you mentioned about BiPAP, CPAP, and everything, okay. And you all discussed about the tube and the subglottic, everything. I was all listening. But let me tell you one thing very sad. This COVID, and of course my advanced age, has finished my anesthetic career because from last 2020, I stopped going. Otherwise, I was still working, both anesthesia and ICU also. I'm very fond of teaching. And about that, I would like to just pass on message to you and to your students also, the participants, that there's a lot of things, facts they know, but unless they discuss, they apply that knowledge with the patient. And that is only possible if they know about it. That do a pre-operative assessment, knowing everything about the patient, and then again on reaching the patient or meeting the patient in the OT, they ask the same thing. Just I will finish just by saying that here in Karachi, the problem is the list is so heavy that sometimes when they see that although the NPO plate is there, but sometimes they go and eat. So you know what I used to do? I used to tell them, uh, if I very widely I would say that in case you have eaten, please tell me very correctly. In case when I give you anesthesia, behoshi in Urdu, so everything can come out and it can go into your lungs and so harm can be done to you. So please tell me correctly. We will do your case today, but you will have to wait for some time. I honestly tell you, every time they told me correctly, yes, yes, doctor, I had this morning. I had breakfast and tea and everything. So what I am saying that the on-table assessment should not just be seen. See, you just see the picture. So see the pre-operative assessment paper. Different. You have to satisfy yourself. Number one, you have to check up everything yourself. Adequately functioning suction, what is the position of the oxygen. Pakistan in Karachi, lot of things are here. It's not that it's like in England when I was in 60s. Far more better in the position is in Karachi and elsewhere in Pakistan, at least in big centers, Islamabad, Lahore. I've seen in all the hospitals in Lahore. So things are improving. But what I'm passing on, telling your students here, don't depend on the assessment of by others. Go through the everything so that you know exactly that everything is in order. I had even the habit of always seeing the adequate supply of oxygen, adequate supply of oxygen, adequate supply of air, and is the additional supply outside working or not? Because I do remember in my previous hospital, the the line burst in the liquid oxygen supply, and I had established a separate supply in the ICU, a different area. Nothing happened to any of my patients, whereas in other parts of the hospital, quite a few patients lost their life. So that's what I'm, don't depend on, you depend on what you see, you have observed, what you have seen. Don't depend. Of course, the technician is there going to help you and all that. I'm not saying. Of course, all the accessories have to be tested. There should at least be this thing, something in England I remember. Has to be at least 2 laryngoscopes. In case the first one fails, you straight away go for the other one. You see, this is what I have to. In fact, I did not know how to contact you. You just unmuted it. Then I never knew how to contact you. So because I'm very poor in my IT technology, it's handling is for smartphone, etc. Anyway, your participants are gradually leaving now, so I'm thankful to you.
Yes, sir.
That
Sir, thanks a lot.
yeah,
And sir,
so
thanks for encouragement. Thank you, sir. Okay. Okay,
thank you.
everybody. So we will meet with a new topic, inshallah. Okay. Thank you. Assalamu alaikum.
Yes.